Dr. Muhammad Walidur Rahman, please come to the dais and deliver your presentation.
Assalamu alaikum and good morning. I'm Dr. Muhammad Walidur Rahman, welcoming you all to my presentation. Before going to the main presentation, I have an acknowledgement and as well as a confession to make. I would like to acknowledge my honorable teacher, Professor Shalil Krishna Banerjee sir, and as well as Professor Kabiruzzaman sir for their kind guidance during preparing the case. And the confession is, during the echocardiography, the patient was not attached with the ECG or respiratometer. So let's go to the presentation. A 12-year-old boy presented to us with abdominal distension for 3 months and breathlessness on exertion for same duration. With this complaint, he was initially treated by a pediatrician and then he was admitted in the Sheikh Russell Gastroliver Hospital. On examination, his vitals were stable, edema was present. As per record, JVP was not raised. Both the first and second heart sound was normal. Ascites was present, and there was just palpable liver. There was no stigmata of the CLD. As the patient presented with the ascites, so they evaluate the cause of the ascites. His CBC was normal. Liver function tests, including the viral markers, were normal. Ultrasonography of the abdomen showed mild hepatosplenomegaly with huge ascites and dilated IVC, hepatic vein, and portal vein. CT scan findings of the abdomen was in accordance with that of the ultrasonography findings, with additional findings of just coarse hepatic parenchyma. Ascitic tap was done. It revealed protein 4.2 gram per DL, and serum ascites albumin gradient was more than 1.1. That is, it was 1.12 gram per DL. Gene expert and ADO was negative, as his serum ascites albumin gradient was more than 1.1 and serum protein was more than 2.5. So cardiac etiology was suspected and he was referred to the cardiologist. So this was the ECG of the patient. Here we can see that there is features of LA enlargement in the V1. There is right axis deviation, and also there is some non-specific QF changes in the V2 to V4. And if we look carefully at the V-lead2, then we'll be able to find that the height of the P wave is not enlarged, but the morphology of the P wave, that is, it is a bit tented, it's not rounded. So it suggests possibilities of right atrial enlargement. Chest X-ray, here if you look very carefully, you'll be able to find that there is a linear area of calcification along the left lateral border, and lateral view showing also the calcification in the inferior border of the heart. Echocardiography was done, which revealed biatrial enlargement, and M-mode echocardiography showed there was good LV global systolic function. EF was 60%. There was diastolic bounce. There was flattening of the LV posterior wall, and pericardium was increased in there was increased pericardial thickness, and also there was calcification. And the pericardial thickness was 0.6 centimeter. If it is more than 2 millimeter, it is thickened. Already Dr. Shardindu has mentioned about the annulus paradoxus. Here it was also present. E by E prime was 4.8. There was grade 3 diastolic dysfunction, and mitral valve flow inflow velocity showed significant respiratory variation. And there was also annulus reversus due to tethering of the LV lateral wall for the constriction. There was presence of biatrial enlargement. There was mild tear, but pulmonary systolic pressure was normal. IVC was dilated, and there was loss of respiratory variation of the IVC. Mediastinal window view of CT scan of the chest showed pericardial calcification in the left lateral border and also the right atrium. Here you can see that marked calcification along the left side of the heart and also the right chamber of the heart. So a diagnosis of chronic constrictive pericarditis with CCF was made, and patient was treated with diuretics, and he was immediately referred to the cardiac surgeon for pericardiectomy and pericardial biopsy. So this criteria has been already mentioned. If any patient presents with heart failure with preserved ejection fraction, we have to exclude constrictive pericarditis and restrictive cardiomyopathy. If mitral inflow velocity is less than 0.8 and inferior vena cava is not dilated, then it is not a case of constrictive or restrictive cardiomyopathy. If EA ratio is more than 0.8 and IVC is dilated, and there is ventricular septal motion abnormality with the respiration, along with more than 8 medial E prime velocity, with the hepatic vein expiratory end-diastolic flow reversal, then it's a case of constriction. If EA ratio is more than 0.8, IVC is dilated, and medial E prime is less than 6, then it might be a case of restrictive cardiomyopathy. So this is the most sensitive sign of constrictive pericarditis, that is respiratophasic interventricular septal shift. Here you can see that during the inspiration, RV is filled with the blood and septum is shifted towards the left. That is opposite thing happens in case of the expiration. So overall, the cardiac etiology contributes 4% of the total ascites cases, but constrictive pericarditis, in case of constrictive pericarditis, 50% of the patient present with ascites. So it's a relatively common presentation of an uncommon disease. It's an elusive diagnostic entity. And the most important part of diagnosis of constrictive pericarditis is to put it in the differential. You have to think that it might be a case of constrictive pericarditis. Otherwise, you will not look for the physical examination findings, or you will not do focused echocardiography. Serum ascites albumin gradient more than 1.1 and total protein more than 2.5 gram DL indicate that there is every possibility of ascites due to cardiac cause. Chest X-ray demonstrate 27% of pericardial calcification only. Respiration-related ventricular shift is 93% sensitive for diagnosing of constrictive pericarditis. Mayo Clinic diagnostic criteria has got 87% sensitivity and 91% specificity for diagnostic constrictive pericarditis. And if constrictive pericarditis diagnosis is not made by the echocardiography, then we can take help from the CT, MRI, or cardiac catheterization. Thank you very much for your patience hearing.
Thank you, Dr. Walid, for your timely presentation. And again, this is very fortunate that we are going to diagnose more and more cases of chronic constrictive pericarditis in Bangladesh. And what was the fate of your patient?
Sir,
did you send the patient for pericardiectomy?
Pericardiectomy and pericardial biopsy, sir. We have not yet the surgery is done.
And because of the sensitivity and specificity of septal bounds, this has put at the top of the list for the diagnostic algorithm by echocardiography and differentiation between constriction and restriction in the Mayo Clinic criteria.
Definitely.
And that is very robust evidence nowadays. Our last presentation is by Dr. Devika Chatterjee.
Can I ask one question? Dr. Manohar, can I ask one question to the speaker?
Sir.
One clinical question. What was the character of the pulse of the patient and what about the JVP?
Sir, initially the patient was treated by a pediatrician and later on the gastroenterologist. In the clinical record, we didn't find that the JVP was raised, and when the patient presented to us, patient was vigorously getting diuretics, so we didn't find the raised JVP. In case of constrictive pericarditis, JVP is raised and there is prominent X and Y descent. And we expect these findings, and along with that, we may find also Kussmaul sign in constrictive pericarditis.
Regarding diagnosis, role of septal movement, Manohar Bhai asked previously, actually it is very, very sensitive and specific. Even IVS, not only IVS, even interarterial septal movement is very much characteristic. Two kinds of movement here, okay. In R2R, there is early diastolic notch. This is known as septal bounce. Another important feature is inspiratory septal shift. Patient asks the patient deep breath, and there is shifting of septum towards the LV. These two things make more specific. Thank you. So septal shift is single one is very much sufficient. In addition, if you see the IVC's dilate just subcostal view, then it's more than 90% is.
Definitely, sir. It has got sensitivity of about 93%.
Another clue I want to share, there is a banana shape of LV. If you think in your mind, the inconstitutive pericarditis is LV-shaped banana. Why it is banana shape? Because there is a lot of calcification constricting the AV group on both sides. We have shown that calcium and AV group. So constriction of AV group making an elongation of the LV. This shape is also very much characteristic for constrictive pericarditis. Thank you.
Thank you. Thank you, Ajayda.